Welcome, everyone. My name is Mohammed Ranavaya, and I'm the Senior Associate Dean for the Continuous Medical Education for Marshall Health Network and Marshall University School of Medicine. It is a great pleasure for me to present the series of the CME On Demand. And part of this series today, we have an excellent speaker, someone who appears young, but is well qualified to tell us about the central nervous system infections and its management. One of our own, a graduate of Marshall University School of Medicine, Dr. Jamila Ranavaya. And in a moment, I will introduce Dr. Ranavaya to you. This activity has been approved as an enduring CME activity for 1 hour of AMA Physician Recognition Category 1 Award by Marshall University School of Medicine, which is accredited by the Accreditation Council on Continuous Medical Education, ACCME. The disclosure of conflict of interest is available on file for Dr. Ranavaya and is part of this presentation. She has disclosed no relevant financial relationship. Dr. Ranavaya is a graduate of Marshall University School of Medicine and holds a degree of Doctor of Medicine from Marshall University. She completed her 4-year residency in both pediatrics and internal medicine, and also successfully completed her board certification in pediatrics and American Board of Internal Medicine. She's currently concluding her fellowship in infectious disease specialty and would graduate from this program in about a month and would be soon joining as a faculty and attending physician. She has done this 2 years of fellowship in infectious diseases at the Department of Infectious Disease, Division of Internal Medicine, University of Kentucky College of Medicine, UK healthcare system. Dr. Ranavaya has presented on many occasions in continuing education conferences, including weekly AIDS Education Training Center. One of her passion is homeless medical care, as well as taking care of people who are unfortunate and do not have many resources. She has presented at the Infectious Disease Week, Fellows Days, American Conference for the Treatment of HIV, as well as Kentucky annual conferences on HIV/AIDS. Dr. Ranavaya, in addition to being a speaker on infectious disease topics, also has mentored many medical students, residents, and interns. And we are grateful for Dr. Ranavaya to have this time for us and make this presentation. So without further ado, the floor is yours, Dr. Ranavaya, for presentation on central nervous system infections. Thank you, and please go ahead.
Thank you. Thank you, Dr. Ranavaya. I appreciate the warm welcome. As he said, I don't have any disclosures, no conflicts of interest. And today's presentation is central nervous system infections and overview. So a quick overview of what we're going to be discussing. The presentation breaks down into CSF interpretation, meningitis and encephalitis, brain abscesses, epidural abscesses, and post-operative central nervous system infections. So, lumbar punctures are one of our key methods of detecting central nervous system infection. So your indications are suspected infection, bacterial, viral, chronic or acute meningitis, but also suspected inflammatory conditions. So you'll see patients receive a lumbar puncture for when there is concern for multiple sclerosis or sarcoid, as well as idiopathic intracranial hypertension. Sometimes patients will need a lumbar puncture to assess for Guillain-Barré or oncologic Mets, as well as administration of intrathecal medications such as chemotherapy. Contraindications towards getting an LP can be broken down into absolute versus relative. So absolute contraindications include infection at your planned LP site. So these are patients who perhaps have an abscess or some sort of trauma to the area. You can consider a suboccipital or C1, C2 approach in these patients, but that is beyond the scope of this talk, as well as relative contraindications when you are things such as a suspicion of increased intracranial pressure secondary to mass effect, coagulopathies, anatomic abnormalities such as prior back surgeries, respiratory distress, particularly respiratory distress that would be exacerbated by the positioning required to obtain a lumbar puncture. One of the important things to keep in mind is that bacteremia is not a contraindication for a lumbar puncture, and getting an LP while a patient is bacteremic will not cause meningitis. The important things to keep in mind when you are performing a lumbar puncture include the anatomy. So you want to make sure that you perform your LP between L3, L4, or L4 and L5 in the subarachnoid space at a level below the spinal cord to prevent injury to the cord. And then anytime you perform a procedure, you are always at risk of developing complications. Complications that we typically see include post-LP headache, spinal hematomas. Most patients will have some level of low back pain. And then if you insert your needle and withdraw it without your stylet, you can risk developing an epidermoid tumor. I've included this slide because I feel like CSF interpretation is something that everyone can always refresh their skills on. So typically when we look at CSF, you want to look at your appearance, the number of white cells, the protein, the glucose, and your opening pressure. In particular, the protein and glucose will really help you distinguish between bacterial and viral. Bacterial typically has low glucose, while viral has normal to high. And then opening pressure is very important when you're looking at fungal meningitis, particularly Cryptococcus. So this is a common situation. Say you only have 1 cc of CSF. Perhaps you have a patient who is, it's hard to get CSF from them, or they're not hydrated well, or they just don't tolerate the procedure. If you are concerned about infection, you need to prioritize getting a meningitis panel and a culture as well as a gram stain. You want to keep in mind, though, that while meningitis panels have greatly advanced our ability to detect infections, they do have false positives and false negatives. In particular, you run the risk of false positives for strep pneumoniae and strep agalactiae, and then you can have false negatives for HSV1 and 2, enterovirus, and Cryptococcus, which are very much HSV1 and 2, and then Cryptococcus you definitely want to treat if it is present. So let's say you have a 45-year-old male who presents with photophobia, headache, and stiff neck. You get an LP, and that shows elevated protein and low glucose. So you know that this is a bacterial infection. What are the 2 most likely bacterial pathogens? So in someone who's 45, the 2 most common bacterial pathogens are strep pneumoniae and Neisseria meningitidis. So we are going to discuss those in a moment, but first a definition from Mandel's, which is the Infectious Disease Guidebook. So the definition of meningitis is inflammation of your meninges, which you identify through an abnormal number of white blood cells in your CSF with symptoms that develop over the course of hours to days. So you'll see in particular when we talk about Neisseria that sometimes meningitis can occur rapidly versus some of the more slow or indolent meningitis. As we had mentioned, the bacterial labs include glucose that's typically lower, so less than 40 milligrams per deciliter. This may vary depending on what lab units your lab uses. Protein greater than 200, elevated white count, particularly neutrophils, and an elevated opening pressure. Something to keep in mind is that these labs are affected by traumatic sticks. So if you have blood in your CSF, you can see falsely elevated white blood cells. So historically, bacterial meningitis was 100% fatal. particularly in the early 1800s through 1900s. In 1913, the introduction of intrathecal meningococcal antiserum improved mortality significantly, but things wouldn't get better until the 1930s when we developed systemic antimicrobials. Patients will often present with the classic triad of fever, nuchal rigidity, and a change in mental status. 41% of patients will present this way, and the older the individual, the more likely they are to present in a classic manner. Other symptoms that you can see include nausea, headache, aphasia, hemiparesis, otitis, or pneumonia. And then once we get to discussing listeria, you'll see that patients with listeria are more likely to present with seizures or focal neurologic deficits. So your most common culprits are split up based on whether you are worried that a patient developed meningitis in the community versus in a healthcare setting. So in the community, the most common bacterial causes are strep pneumo, Neisseria, and listeria. If you are dealing with a healthcare associated meningitis, that is typically after a neurosurgical procedure such as a craniotomy, a shunt, an external ventricular drain or EVD, or head trauma, then you are more worried about gram-negative bacilli and staphylococcal illness. And then again, your age will affect the pathogens that you're concerned for and empirically covering. So patients who are young, so less than a month old, so your neonates, are more likely to have listeria, as are patients who are older than 50 to 60 years of age. Additionally, your patient's history will play a role in what you want to empirically treat. So immunocompromised patients, such as will also have different bacteria that you would prefer to cover. So steroids. This is a big question that you see a lot in practice, whether to steroid or not to steroid. Steroids have a proven benefit in patients with pneumococcal meningitis, and they do their best work between if you give them during the first antibiotic dose versus like around the first antibiotic dose. Typically, the benefits of steroids in patients with pneumococcal meningitis is that they reduce hearing loss, neurologic complications, and mortality. You typically only give them for 4 days, and they are not very helpful in listerial meningitis. In particular, there was a study in France that showed that steroids and listeria may actually increase mortality, but it was a very limited small study. Nevertheless, if your patient has listeria, we discontinue steroids, and you don't typically see them used in healthcare-associated meningitis. So we're going to break down the top 3 bacterial causes in this presentation. So we're going to talk about strep pneumo, Neisseria, and listeria. So strep pneumo is your most common cause and you will of meningitis in the community, and you will see that there has been an increase in penicillin resistant strains over time. So it is very helpful to know your particular hospital's antibiogram to understand the resistance patterns that you may be dealing with. So if you have a patient whose strep pneumo strain is susceptible to penicillin, you can treat with penicillin or ceftriaxone. If you have a patient where you are not susceptible to penicillin, but you are susceptible to ceftriaxone, then you can treat with just ceftriaxone or cefotaxime. If you have an intermediate susceptibility to ceftriaxone, you would still do vanc plus ceftriaxone. And then if it's resistant, you would do vanc, ceftriaxone, plus either rifampin or fluoroquinolone. Regardless, the duration of therapy is typically 10 to 14 days. Moving on to Neisseria, which is our second most common adult community-acquired meningitis. It typically occurs in late winter and is often mistaken for the flu. So patients present with rapid onset within 12 to 15 hours, fever, nausea, vomiting, headache, myalgias, which is why it can easily be mistaken for the flu. You'll notice that a rash is a major component of Neisseria meningitidis diagnoses when it comes to meningitis. So over 50% of patients will present with petechiae, and typically these petechiae can coalesce into larger purpuric ecchymotic lesions. So on the picture in this slide, you can see that this patient has developed purpura and ecchymoses. The big things to watch out for are DIC, shock, and purpura fulminans. So purpura fulminans is a thrombotic disorder where endotoxin-induced damage occurs in your endothelial cells, followed by rash, vascular thrombosis, necrosis, and DIC with dermal hemorrhage. You typically treat Neisseria for 7 days, and you want to treat it with ceftriaxone or cefotaxime. And if you're penicillin susceptible, you can actually drop down to ampicillin or Penji. Additionally, Neisseria does have some risks, so you need to use droplet precaution for 24 hours after starting effective therapy to prevent transmission. That leads me into who needs prophylaxis. So this is a common question both on the boards and the wards. You'll see, for example, a respiratory therapist who intubates a patient in the ER and things are happening rapidly, so they don't remember to grab a mask. Then the patient turns out to have Neisseria meningitis. So in a person who has unprotected contact with respiratory secretions or saliva during an intubation, you want to provide chemoprophylaxis. The same goes for travelers who are sat next to a patient on a flight for greater than or equal to 8 hours, or household members, childcare contacts, or anyone exposed to oral secretions. Typically, you want to provide prophylaxis in patients who have exposure 7 days prior to symptom onset, and you want to treat with rifampin, ceftriaxone, or ciprofloxacin. If there's ciprofloxacin resistance locally, you can treat with azithromycin, but it is not the best choice. Chemoprophylaxis typically works best if you catch people within 24 hours and you don't want to provide prophylaxis greater than 14 days after exposure. Moving on to our third most common cause, listeria. So listeria, as I had mentioned earlier, is more common in neonates, so those less than 1, and those who are greater than 60, presenting a bimodal distribution. Typically, other people at risk include pregnant patients, alcoholics, people with immune compromise. So those are patients living with HIV, patients who have transplants or who have recently had chemotherapy, or who are on long-term steroids. Listeria is typically isolated from the environment and can be caused by outbreaks with contaminated food. In med school, they really hammer down that you can get this from soft cheeses, but you can also get listeria from coleslaw, raw vegetables, milk, contaminated turkey franks, alfalfa tablets, cantaloupe, diced celery, vegan cheese, processed meats, and hoghead cheese, which is a delicacy in other parts of the world made from hog's head and feet. Additionally, you want to treat listeria with ampicillin or penicillin G, and you can use gentamicin for synergy. Typically, the duration of therapy depends on your patient's immune status. So patients who have a functioning immune system, you would typically treat for 3 to 4 weeks. The worse your immune system gets, the longer you treat. So 4 to 8 weeks for patients who are immune compromised, and 6 to 8 weeks if you have brain abscesses or cerebritis. And if your patient is penicillin allergic, as we do see out in the community, you can desensitize patients with the help of a local allergy immunologist, or you can treat them with Bactro. Moving on to viral causes of meningitis. Viral causes of meningitis typically result in what is known as an aseptic meningitis. So these patients will present with CSF pleocytosis, negative CSF or blood culture, and a normal neurologic exam. Sometimes, though, they present with fever, headache, nausea, stiff neck, and photophobia, which are our typical meningitic symptoms. Typically, you see enterovirus as the cause of identified aseptic meningitis, so that's 55% of all patients. You can also see other causes such as Japanese encephalitis, Ebola, dengue, Zika, and chikungunya. Typically, you treat aseptic meningitis with supportive care unless you are dealing with a HSV or VZV meningitis, in which case you need to treat with antivirals. So your labs that you would typically expect include a white count that is less than 250 with lymphocytic pleocytosis, and you will also see elevation in protein and normal to elevated glucose. So moving on to encephalitis, which is very similar to meningitis, you have a patient who's 75 years old and he presents to your ER with fever, headache, and flaccid paralysis. An LP is performed and your IgM testing is positive for West Nile virus. What is your preferred therapy? So, just as in a meningitis, unless it is HSV or VZV, the therapy is typically supportive. So, definition of encephalitis is an inflammatory process of the brain parenchyma associated with clinical and laboratory evidence of neurologic dysfunction. So, part of this diagnosis is clinical. And the big difference between meningitis and encephalitis is that in meningitis, you have normal cerebral function versus encephalitis, where it's abnormal. Viruses are the most common causes in the US of encephalitis, but you can also have non-infectious causes such as autoimmune or post-infectious, encephalitis, paraneoplastic, neoplastic, or collagen vascular disease-related infections processes. 60% of encephalitises have an unidentified agent, but viruses, bacteria, and like I said, autoimmune inflammation are your more common causes. And patients who are very young or very old are at higher risk. I'm not going to read through all these symptoms, but typically is a pretty broad range. So your fevers, your headache, and your seizures, but also aphasia and ataxia are also signs of an encephalitis. Typically, if you're dealing with VZV or HSV, you can also see rash. So in shingles, you can see like the grouped dermatomal shingles rash. So these are your common causes of viral encephalitis, and they range from completely fatal to relatively benign. So on the one end is rabies, where there is no cure, no reliable cure. And on the other end is enteroviruses. And somewhere in the middle, the rest of these fall. So in terms of enteroviruses and arboviruses, you typically see seasonal distributions, so summer and fall. You can see West Nile virus as the most common cause of proven viral encephalitis in the US. And like I said, symptomatic care is typically how you treat it. In regards to arboviruses, you break them down as mosquito-borne versus tick-borne, and your distribution will vary based on your geography. So if you're in the Northeast, you're more likely to see Powassan, which is carried by ticks, and Eastern equine, which is carried by mosquitoes. If you're in the Midwest and South, you can see St. Louis encephalitis, which is mosquito-borne. HSV is your most common sporadic encephalitis, and you won't see a seasonal or gender predilection, but you will see a bimodal age distribution. So again, the very young and the very old, and it's fatal if untreated. So these are patients where if you have a concern, you want to start acyclovir. The reason that measles makes this list is that there is a 20% mortality with post-infectious measles encephalitis, and then there is a 100% mortality in subacute sclerosing panencephalitis, which is a well-known side effect of measles infection. Subacute sclerosing panencephalitis often develops at an develops down the road from having measles infection, and you can see seizures, deterioration of cognition and motor function, and ultimately death. Diagnosis and management is typically getting an LP and sending off cultures and PCR. And then if you have a patient who has a rash that has a vesicle, the best thing to do is to unroof it and send a PCR from that. If you are suspecting viral causes, like I said, you'd want to start acyclovir. A lot of times these patients get imaging, so CT is helpful to rule out space-occupying lesions pretty quickly, whereas an MRI helps to determine if you are seeing demyelination. You can also get an EEG, particularly if you're concerned for seizures, and you often monitor these patients in the ICU because of increased intracranial pressure and autonomic dysfunction. We also tend to involve our neurology colleagues who can provide recommendations on antiepileptics. Moving on to brain abscesses. Let's say you have an 18-year-old who presents with several weeks of sinus infection, which prevented her from seeing a dentist. This is pretty common in teenagers, young adults who, if they're sick, they're not going to want to come in. So an MRI is obtained because you're concerned and you find a brain abscess. What kind of bacteria are you suspicious are at play? So when I think of brain abscesses, I think of anaerobes and oral flora. So the definition is a focal intracerebral infection with localized cerebritis, which becomes a collection of pus surrounded by a vascular capsule. So essentially it organizes into an abscess. Before the late 1800s, this was uniformly fatal. And then, once we developed surgical drainage, that helped cure very specific patients, but antibiotics and the introduction of stereotactic brain biopsy and aspiration ultimately helped to improve mortality significantly. There is a male predominance for brain abscess with a 2-to-1 versus 3-to-1 predominance and a median age of 30 to 40 years. In the past, we used to think that that otogenic, so ear infection related abscesses were more common, but that has decreased over time with an increase in post-traumatic and post-operative brain abscesses. Typically, the pathogenesis is that bacteria invade the brain by direct spread or hematogenous seeding, and you're more likely to see it in the frontal temporal lobes versus the frontoparietal, parietal, cerebellar, or occipital lobe. And then, as noted on the slide, you see tissue damage, which is caused by the host's acute inflammatory response. So, predisposing conditions. So you'll see that there is an age range here. So paranasal sinuses can cause brain abscess in those in the range of 10 to 30 years old. You can often see ear infections in those who are less than 20 or those older than 40. Trauma, particularly penetrating trauma, surgery, and immune compromise. You'll notice unhealthy population is listed, and that's from studies done overseas that notice the more unhealthy your population is, the more likely you are to have higher rates of brain abscesses. And as I mentioned before, mortality has improved with new innovations. So the rate is now listed as being anywhere between 0 and 24%. And patients who have a brain abscess often have neurologic sequela, and that range has been quoted as between 20 and 70%. I've included this slide because I think it's helpful to know which predisposing condition you think has caused the brain abscess, because that will help you determine which isolates that you target. So in particular, there is a big difference between the isolates that you would be concerned for in a person living with HIV and those that you would be concerned about in someone with otitis media. For example, in a person living with HIV, you're more concerned about toxoplasmosis, nocardia, fungal infections like cryptococcus, whereas someone with otitis media, you're more concerned about Bacteroides, Prevotella, and Streptococci. Other important populations include patients with transplant, so they have higher risk of Aspergillus, Mucorales, as well as tuberculosis. And then patients who have congenital heart disease, you want to keep your oral flora in mind, such as your upper respiratory flora, such as strep and Haemophilus. So focal neurologic deficits under your physical exam will be observed in up to 50% of patients within days to weeks after they have the onset of the headache, which is one of the first symptoms. You can also see neck stiffness, altered mental status, and vomiting. The typical triad is a unilateral headache, fever, and focal neurologic deficits. If you have a patient who has sudden worsening of their headache followed by meningismus, you need to be concerned for rupture of an abscess, and that is a neurologic emergency with an 85% mortality rate. You'll also notice that seizures are listed as a possible physical exam finding, and that happens in 25% of cases and can be your first manifestation that something is wrong. If a patient develops papilledema, that is a late finding, and if you're more likely to see a third and sixth cranial nerve deficit before you see papilledema. So diagnosis and treatment is really related to imaging. So you want to do MRI with contrast as it's more sensitive for early cerebritis. But if a patient can't get an MRI, say, for example, they've recently had a pacemaker placed or they have hardware that makes it impossible, then you can do a CT. After you have determined that you have an abscess, you want to get stereotactic guided aspiration and drainage with culture. You don't need to necessarily get an LP unless a patient is immune compromised. And you always want to get blood cultures before starting antibiotics if you are able to. Based on your patient's risk factors, you can also look for toxoplasma IgG, anticysticercal IgG, and cryptococcal antigen. You become more concerned about tinea solium or cysticercosis if you have a patient, for example, who has traveled. A large part of ID is knowing your patient's history and where they've been. So if you have an international traveler, you may be more worried about parasites. Moving on from brain abscess to epidural abscess, these often feel relatively connected. Let's say you have a 37-year-old patient who presents with IV drug use. You find that they have worsened paralysis of their lower extremities, plus new findings of a spinal collection on MRI. What's your next step? So, I've seen patients like this, and the next step is always to talk with your neurosurgeons and see if this patient needs emergent operative intervention. So the definition of an epidural abscess is a localized collection of pus between the dura and the skull, or the dura and the vertebral column. These are typically from hematogenous spread and direct extension from infected contiguous tissue. So a vertebral body or a psoas muscle, as well as direct inoculation into your spinal cord. So those are patients who perhaps have had a spinal or an epidural anesthetic procedure or surgery. A third of patients will have no identifiable source, but your predisposing factors include injection drug use, dental abscesses, infected catheters, particularly vertebral osteomyelitis with MSSA, and infected endocarditis can be a risk factor. Your clinical findings typically follow a specific pattern. So if you have neurologic deficits, it will start out as back pain, followed by shooting electric nerve root pain, followed by bowel bladder weakness, sensation changes, and then ultimately paralysis. You want to catch this before you reach the later stages, as it can be irreversible. Some patients will present as well with your typical fever, pain, and headache, which is pretty nonspecific. But if you have focal vertebral pain, radicular pain, and paralysis, that is when you are definitely concerned that you are dealing with an epidural abscess. Your common pathogens are Staph aureus, and notice that I did not differentiate between MRSA and MSSA because it varies based on the population. You will also see gram-negatives such as E. coli and Pseudomonas, particularly in patients who have IV drug use. You'll see streptococci, and you'll notice that coag-negative staph is on the list. Coag-negative staph in the blood is often considered a contaminant, but when you see it in CSF, or in this case in an epidural abscess, you become more concerned that it is a true pathogen. Diagnosis and management really starts with imaging. So you really want MRI. MRI is recommended over CT because it does a better job of seeing the spinal cord and epidural space, both in sagittal and transverse sections. It also helps to better identify osteomyelitis, spinal cord lesions, and discitis. Typically, you want to get surgical decompression, drainage, and culture, and these patients will require 4 to 6 weeks of antibiotics, and you want to cover anti-staph as well as gram-negatives, like I mentioned. So a good example of a starter regimen would be vancomycin and cefepime until you have a better culture-based understanding of what the patient is infected with. Moving on to our last topic, healthcare-associated meningitis. You want to make sure that you assess for neurosurgical procedures, as this can be a strong reason that you develop a healthcare associated meningitis. So these are patients who have CSF leaks, craniotomies, shunts, or head trauma. Your common bacteria will be Staph aureus, Klebsiella, and Pseudomonas. And your empiric therapy is typically vancomycin plus cefepime or vancomycin plus meropenem, as if you have a patient who has a risk of an extended spectrum beta-lactamase, you'd want to start with that regimen first. You can also consider vanc plus ceftazidime if you are worried about a resistant Pseudomonas. Typically, you would treat for 10 to 14 days and remove your hardware if there's hardware present and if it's safe to do so. Important to keep in mind, CSF shunt infections are more common than typically expected. So the risk of infection in a shunt is 5 to 15% of all CSF shunts during their lifetime. Most commonly, you'll see infections within the first 6 months of placement, but a single revision surgery is associated with a 3 to 4-fold risk of infection, and 2+ revisions increase this by a 6 to 13% fold increase. Patients typically present with fever, headache, nausea, and lethargy. You'll find that their families are often the ones who will provide you this history. And you can see purulent drainage from a wound with inflammation along the shunt path. Your common species are coag-negative staph and Staph aureus, so that's 2/3 of your infections, and your enteric gram-negatives, so your E. coli, your Pseudomonas, your Proteus, and your Klebsiella. Less commonly, you'll see Cutibacterium, which was previously known as Propionibacterium, and Viridans root strep. Diagnosis and management starts with a shunt series, followed by CT and MRI, a tap of the shunt to obtain CSF to send for studies and cultures. You also want to get blood cultures and try to get the shunt removed and replaced if possible. So the takeaways from this presentation, and that is that an LP is the first step towards diagnosis of meningitis encephalitis, but it's also very helpful if you're concerned about a CSF shunt infection. Encephalitis always has altered neurologic status. Meningitis does not. MRI with contrast plus a biopsy or culture are helpful in both brain abscesses and spinal epidural abscesses. And if you have a post-operative infection, you want to be concerned for coag-negative staph and Staph aureus, but don't forget to cover for your gram-negatives such as Pseudomonas. That's the end of my presentation, and thank you for listening.
Thank you very much, Dr. Ranavaya, for a very good presentation that gave us a lot of practical information and knowledge. I have few questions that I usually ask of all of our speakers to further clarify some of the things you have talked about. So the first question I have is, you talked about evaluating patients with suspected meningitis or encephalitis. What practical clinical features help you decide how urgently to perform lumbar puncture versus obtaining neuroimaging first?
So part of what we do to determine whether you want to get neuroimaging is to get a good history on the patient. So if they have a history of a CNS tumor, that would make you a little bit more concerned for a need for imaging prior to LP. But often the clinical signs that you would be concerned about are altered mental status. And if you have a patient, I've often heard attendings say, if you are considering an LP, then you should obtain an LP. And it really is a case-by-case basis on the risk of a patient requiring imaging.
Thank you. So the second question I have is, your presentation emphasized that only a small amount of CSF may be available sometimes. In a situation like that, how should clinicians prioritize CSF testing, especially between culture, gram stain, meningitis, encephalitis, PCR panel, and other studies?
So I feel like this is very this question in particular, it would probably get a dozen different answers from a dozen different infectious disease specialists, but personally, I would prioritize the PCR. So the PCR gives you the most bang for your buck and provides an informational descriptor of which viruses and bacteria you might have based on how PCRs work. If I were to number those in an order of most important to me to least important, I would get the PCR, then I would get the gram stain, and then the culture. The gram stain can provide you a lot of information. And sometimes cultures don't grow, particularly if a patient has been pre-treated, as they often are, because you should not delay antibiotic therapy in order to obtain CSF.
Thank you. So another question I have is, for suspected bacterial meningitis, how should clinician balance the need for immediate empiric antibiotics with the desire to obtain adequate diagnostic cultures, particularly when the patient has already received antibiotics before lumbar puncture?
So that dovetails beautifully into my prior answer. So we always say that as important as cultures are, you have to treat the patient. So you would want to treat with antibiotics and still get an LP and do your best, because clinically that matters more than having an answer to what particular pathogen you are treating. Often we stay broad in those situations until we have more information. but definitely prioritize giving the patient antibiotics and antivirals, antifungals before receiving an LP.
Thank you. One of the other question always comes to mind is, particularly when I listen to your lecture, which distinguishes meningitis from encephalitis by the presence of abnormal cerebral function in encephalitis, as you mentioned. In the real world practice, what are the most important clinical clues that should prompt empiric acyclovir while waiting CSF PCR results?
So in the real world, encephalitis and meningitis can often be a meningoencephalitis. So you can see a lot of overlap. But the patients that I would be most concerned for are patients who have a history of shingles or or prior HSV outbreaks, who would definitely you would be more likely to put acyclovir on sooner rather than later, and then patients who are immune compromised. So you see it you see patients started on acyclovir pretty frequently in the transplant and immune compromised space. And then you always want to do a thorough exam of the patient. So if you see skin findings that are concerning for HSV or VZV, then you want to start acyclovir. A lot of times people start it as their broad empiric therapy, and then they just peel it off once they get the PCR back and see that it's not present.
Thank you. So the final question I have, and you have had a very long evening, and I appreciate it very much. Thank you. The final question I have for you is for brain abscess, spinal epidural abscess, and post-operative CNS infection. Imaging and source control were emphasized in your presentation. What are the key situations in which medical therapy alone may be insufficient and early neurosurgical or surgical consultation becomes critical?
So typically surgical consultation is critical when you start to see the progression of symptoms to those red flag signs. So patients who are having bowel and bladder incontinence, muscular and lower extremity weakness, or upper extremity if you have a higher epidural abscess. Essentially, when you are approaching the point of no return with neurosurgical symptoms, that would be when medical management alone will not provide adequate relief for the patient.
Thank you so much again for a very enlightening presentation, along with all the questions that you answered so thoughtfully. Much appreciated. And I thank you, all the audience, for participating in CME On Demand Enduring CME activity titled CNS Infections, presented by Dr. Jamila Ranavaya from University of Kentucky. This program has been reviewed and approved for AMA PRA Category 1 credit. In accordance with the ACCME accreditation standards, to receive CME credit, you must complete the evaluation form. Your feedback is essential for assessing the effectiveness of this activity and for improving future educational programs. Physicians should only claim credit commensurate with the extent of their participation in this activity. This content has been developed in compliance with the ACCME's standards for integrity and independence in accredited medical continuous education, ensuring that it is free from commercial bias. To complete your evaluation and claim your CME credit, you may scan the QR code with your phone or click on the link below to access the evaluation form. Once again, I myself and on behalf of the CME Division of Marshall University School of Medicine am grateful for our speaker as well as our audience and your commitment to lifelong learning and your dedication to improving patient care. Thank you for your participation.